Good afternoon, everybody. Welcome to this session on ICP management. We apologize for the delay in starting the session. Apparently, Dr. Leroux has some problem in logging in, but we hope he will join us soon. So my name is Geert Meijfreut. I'm from Leuven in Belgium. As a disclosure, I must say that I was one of the co-authors of the two recently published CIBIC guidelines, which is a scientific disclosure because so this means I participated in the consensus that created these guidelines, and I have no commercial disclosures here. In the next 30 minutes, we will discuss, and I hope I will be able to discuss with Dr. Leroux as well, because otherwise I have to discuss with myself, which is maybe, there he is. Hi, Peter, welcome.
Good morning.
Good afternoon over here, and good morning over there.
It's, nice and early here. And I just had to deal with something in the ER, so got delayed a little bit.
Okay, no problem. So we just started. I just introduced myself. Maybe you can introduce yourself.
Peter Leroux. I'm a neurosurgeon in Philadelphia, in the United States, with a long-standing interest in neurocritical care.
Yeah. So this session is about intracranial pressure. We think intracranial pressure is still a very important parameter to follow. And we know that if ICP becomes refractory to treatment, that the outcome for the patient will be very bad. I think over the past decades, we've sort of moved from the insight that ICP needs to treat it at a certain threshold to new concepts such as pressure time dose. And we know that it's difficult to quantify at the bedside, but we still see that it's more prognostically important than crossing a certain threshold. The ICP is, of course, not a number in isolation. So it means that you should look at the reason why it's high, the underlying physiology, and try to solve the problem that way. You've seen the recent CIBIC guidelines published, and basically what the CIBIC guidelines do is, in the absence of evidence on a lot of intervention, it's an expert statement, and it's sort of a ranking of intervention based on risk and benefit, which means that tier 0 treatments are estimated to have a relatively low risk compared to their potential benefit. And as you move up into tiers like tier 1, tier 2, especially tier 3, tier 3 treatments are considered extremely risky and should only be considered in a scenario where you are with your back against the wall and see no other option. What is also very important in the CIBIC guidelines is that it's always like that, you have to look at the small letters. It's like in a contract that you get, which means what is very important is the concept of neuroworsening, is moving from a tier to another through neuroworsening. And then also inter-tier recommendation. Actually, what inter-tier recommendations is simply look and examine, look to your patient, examine your patient, and to evaluate what you did is right, and to look for an underlying cause that is easy to resolve. I don't know if you have anything to add to that, Peter?
No, I think sort of the key points for me are the following. There's no question that increased intracranial pressure is associated with mortality, not necessarily outcome. And the higher it is and the more refractory to treatment, the greater the mortality. Where you can start to tease out, is somebody going to have a favorable outcome versus a less favorable outcome? That's when multimodality monitoring becomes important. And therefore, that is a key point when monitoring ICP is, and you've already alluded to that, it really shouldn't be looked at in isolation. And it's not simply a threshold where one size fits all. So, there's a fair amount of data now suggesting that just simply exceeding a threshold may be less important than the total dose or the area under the curve, or how that ICP evolves over time. And that, excuse me, fits in with the concept of neuroworsening. In other words, somebody with an ICP of 23 who on CT has cisterns that are open, and if you stimulate them, has a short rise but a quick return to their normality, is different from a person with an ICP of 23 and say a enlarged pupil or tight cisterns, or if you stimulate them, the ICP stays up and takes a long time to go down. They're different patients, even though they got the same threshold number. In trying to treat patients, obviously we're making the assumption that you have an ICP monitor in place. And the best ICP monitor is really a parenchymal monitor versus a ventricular catheter. There's some data now suggesting that that is the case. And there are different reasons for that, but obviously that can be patient specific. So for an example, a patient with hydrocephalus is better served with an EVD than a parenchymal monitor. And personally, in the absence of hydrocephalus, I prefer a parenchymal monitor. There's been a lot of work done on non-invasive monitors, and they are evolving. We don't have one that is currently robust enough to use on a routine basis, but there are conceptual monitors that I think will be online in the near future that we can use. Having said that, there are also protocols that exist that really stemmed out of the BEST TRIPS trial. And please remember, BEST TRIPS trial was not a trial of ICP monitoring. It was a trial of two therapies. But one of those was what's called ICE, or the way of treating ICP without an ICP monitor based on the clinical exam and imaging. And so I think importantly, one wants to avoid the concept that we're simply treating a number, but rather want to look for the reason why that's increasing. And what CBIC has really done has sort of made that an important point, i.e. the concept of neuroworsening, and you work through a variety of tiers of care rather than a single one therapy. Tiers of care can seem fairly complex. Having said that, BOOST 2, which was a trial that really looked at multimodality monitoring, demonstrated the ease and feasibility of these tiers of care. And while it did also demonstrate that additional monitoring was helpful, it really did show that these tiers are something that can be done in the real world and perhaps are a very valid way of approaching it. So as Geert has indicated, the tiers have several very options in them. You don't have to do every single one of those options. You have to do what's appropriate clinically for the patient. And that, I think, is where conceptually we are now, and that is sort of individualizing our care and targeting our care. So I think that is perhaps the most important thing, is really trying to understand each individual patient and treating them appropriately to decide how best to manage them.
Yeah, very good. And I see we already have 4 very interesting questions. And I think let's start with the first one. The first question is one of our viewers who asks us about hyperosmolar therapy. What do you prefer for hyperosmolar therapy and why? How does the underlying condition affect your choice? There's a lot of controversy about hyperosmolar therapy. And in the literature and also at conferences, there's always this fierce debate of the hypertonic saline versus mannitol schools, let's call them. So if we go to the evidence, there's actually no outcome evidence suggesting a benefit of the one over the other, in spite of this fierce debate. And so actually, personally, I have no preference. I use what is available, and in my hospital, it's usually mannitol. Now, we know that mannitol has certain side effects where you don't want to use it, but the same is true for the hypertonic saline. I don't think the underlying condition is important for the choice. Of course, if you have a patient who is hyponatremic, you might prefer hypertonic saline. We have published the fluid guidelines 2 years ago, the ISICEM fluid guidelines. We have acknowledged the lack of evidence there. And then a very interesting paper by Daniele Poole, because I think mannitol is, of the 2 agents, the one that is most under criticism. But still, there's no outcome data, but it works very well in reducing the ICP. And Daniele Poole published a paper in Neurocritical Care last year, where he did a meta-regression analysis of all the studies available, where he was able to demonstrate that it does reduce ICP, and it works best if the ICP is elevated. So I don't know if it answers your question. I don't know if Peter has any additional comments to that, because maybe he uses hypertonic saline more than I do.
I think use it in a similar way to you do. We tend to start with mannitol first and then use hypertonic saline. Having said that, in somebody who is hypotensive or has low sodium, then hypertonic saline may be preferable. The efficacy of both is very similar in their papers that demonstrate both are better than the other, right? So it's not a clear-cut answer, and some of that depends on the methodology of the paper, and then are they equi-osmolar in terms of how they've been used. I think what's important is that you should not be using mannitol as a non-bolus continuous infusion. In other words, you give it when the ICP is increased. And secondly, you don't just schedule an infusion of hyperosmolar therapy every 4 to 6 hours and say, okay, I'm just going to run in hypertonic saline every 6 hours because I think this patient might have a problem. So those are two important things that you should not do. So my own preference is I start with mannitol. If they don't respond, I give hypertonic saline. The exception being if they have low sodium or low blood pressure, I might give hypertonic saline first. I don't think the condition necessarily makes a difference. One might argue in subarachnoid imaging.
There's another related question about MCA stroke, the last question, and hypertonic saline. And I think the same answer could apply here. But a malignant MCA stroke, I think, is one of these conditions where you should move to hemicraniectomy really early. I don't think you need to wait. Waiting for the surgery, you can give hyperosmolar therapy, but I would, if you think that there's an indication for a hemicraniectomy, I don't think you have to wait too long in doing that. Peter, do you agree?
I think if you've got true malignant MCA infarct and you think they've got high ICP, you're probably better served by a decompressive craniectomy than trying to avoid it with hypertonic saline. And again, the data from randomized controlled trials is pretty convincing. Some of the early data when the Hamlet and Destiny and so forth were pooled, and that's going back about 10, 15 years, it was a very small sample size. But there have been multiple meta-analyses since then that have include, Decimal, Hamlet, both Destinies, Head First, and a variety of other trials. And decompressive craniectomy is associated with lower mortality and better MRS. So, and those meta-analyses now include, 300 plus patients. So it's a reasonable, I think if you think you need to do something like a decompressive hemicraniectomy, you should proceed to that. Again, there are issues that come in with patient age and the ethics and so forth, but I would rather do a decompressive hemicraniectomy than use hypertonic saline.
Yeah, fully agree. Another question, also very interesting, the intracranial hypertension and neuroinfections. Is there a place for ICP measurements, hyperosmolars, drains? And I think it's one of these fields that is probably under research because if a patient with a severe infection develops intracranial hypertension, the mortality is really high. I would, especially in young patients and in children, I would tend to be aggressive. And we have put parenchymal probes in these patients and treated them with an intracranial hypertension protocol. The one difference with infections is that here you would give steroids as well, which you wouldn't do in TBI. So it's an additional treatment for edema, and it might reduce the ICP, although not in the acute way. But we have treated patients with a classic intracranial hypertension protocol with infections as well, with good results. especially, I think for the measurement is probably those patients where you would put in an EVD as well. Peter, do you have similar experience?
Yeah, again, there's not a gigantic experience, and certainly in the US, we don't see as many infections as you might see, say, in sub-Saharan Africa. So when you're dealing with an infection, you have to decide what is it. If you look at, say, a subdural empyema or a brain abscess, there the treatment's surgical. And obviously you treat in ICP in that circumstance. And in those circumstances, I treat those patients similar to how I might treat traumatic brain injury. In somebody with meningitis, there is reasonable data that giving steroids to certain types of bacterial meningitis upfront can be valuable. There's some interesting differences that depend on your geography and so forth, but they do seem to make a difference. Something like tuberculosis may lead to high ICP because you get hydrocephalus. So in those patients, it's an EVD. But I think if you think they've got high ICP, then you treat the high ICP. The science is really not infection specific, and so we tend to use what we will use in traumatic brain injury to guide how we manage these patients.
Yeah. Do you use what we usually do is that it's actually based on the CT, whether we think, okay, is this a risk for intracranial hypertension or not? Do you think in these patients there could be a place for the non-invasive estimations of elevated ICP before you decide to move to, for instance, an EVD or a parenchymal probe?
Yeah, I think that's probably the best role for non-invasive monitors now in deciding if you want to do something invasive. So, if somebody's got compressed systems, but they sort of still awake and following commands, you don't necessarily have to put it in a monitor. But let's say it's a bacterial infection, they got compressed cisterns, they look very tight on CT, and they comatose. Measuring optic nerve sheath diameter or pulsatility index on TCD or other non-invasive monitors might give you a sense that, oh, okay, I should do something. The other side of it, if they've got hydrocephalus and they have a decreased level of consciousness, well, then an EVD is something that you'd place. So the non-invasive monitors, I think, do play a role in trying to decide that, and one might argue they play a role in other conditions, with metabolic encephalopathy, say liver failure, or where there's a coagulopathy where it's dangerous to assert a monitor. They can be useful to guide your therapy.
Yeah, indeed. Okay, let's move to the next question. There's actually two similar questions on sedation strategies. One is more broad. What are the sedation strategies? And do we have upper dose limits for opioids? And the other question is, do we give deep sedation to a calm, tubus-tolerant, non-coughing patient? Now, to start, maybe the first question is the easiest one. The calm, tubus-tolerant, non-coughing patient with no ICP problem doesn't need deep sedation. But of course, sedation in this population is something else than in the general ICU. In this population, sedation is a treatment for elevated ICP, or can be a treatment for elevated ICP, which means that in the CIPIC guidelines, we said the tubus-tolerant, calm, non-coughing patient is tier 0, and anything above that is tier 1. Probably, there's no upper dose limit for opioids to me. It's about pain assessment and ventilator tolerance. So some patients need a lot, some patients don't. Some patients are opioid dependent before they come to the ICU. We usually start with propofol because it's easy to steer, but of course there's an upper dose limit, and it's quite clear. A couple of years ago, we've seen a couple of referred cases of propofol infusion syndrome that were quite severe. So it does exist. So long high dose of propofol is not a good idea, which means that you would have to associate other sedatives. And then I think in our hospital, probably the second sedative would be midazolam. And you can discuss about that because the pharmacokinetics of midazolam are not so attractive for a neuro patient. But on the other hand, once you're in that track of intracranial hypertension, tier 1, tier 2, this is probably not the sort of patient that will awake early anyway, but still, it's not very attractive indeed. And then after that, it becomes more complex, because if you still have a feeling the patient is insufficiently sedated, and that insufficient sedation either through your EEG control or through the ICP, you think that the metabolism of the brain is too high, and that there's an imbalance in consumption and supply, you have to choose other drugs, and there it becomes difficult. Dexmedetomidine is something we sometimes use, although some patients become bradycardic with it, but it is an attractive drug. And also in the weaning phase, it can be attractive. And what we also use, and this might sound like cursing in the church, but it's ketamine. Ketamine actually, in combination with other sedatives, does not increase the ICP, and has been shown in TBI as well as non-TBI. And there's a very elegant summary of the literature in both indications by Fred Seiler, that you can safely give ketamine in sedated patients, and that they will reduce the intracranial pressure. And then the let's say tier 3 back against the wall option here is the barbiturates, also with low levels of evidence, but they do work. You can give if you're uncertain about it, you can just give a bolus and see what happens on the EEG and the ICP before you decide to continue to an infusion, because obviously once you start with a barbiturate infusion, you know that for the next couple of days your neurological assessment will be impossible. I don't know if this is somehow similar to what you do in Philadelphia, Peter.
Pretty much. I mean, I think if you're going to sedate somebody, you want to sedate them. You know, a patient that is coughing or straining or restless is going to have a high ICP. I mean, that's what happens in you and I. If we awake and we cough or we sneeze or we strain, our ICP goes up. We have the compliance to correct for it. So I prefer short-acting agents, and usually up front it might be a narcotic and a sedative. So, fentanyl, morphine, midazolam is one combination. Propofol is good as well because it's short-acting, and if you wish to wake the patient up and examine them, you can do that. There are issues with that. So if somebody's got high ICP, you don't need to do neuroawakening to see what their condition's like. The dexmedetomidine, ketamine, they all use, and I think one has to perhaps have sort of a protocol in your ICU that most people are familiar with, understand the pharmacokinetics and pharmacodynamics of the drug, and so become familiar with the use. But bottom line, there's several agents to choose from. Shorter acting are preferable, and if you're going to sedate, make sure you sedate adequately. I often tell patients, or rather not patients, but physicians, let's say a patient comes in and they're on the medicine service or the trauma service, and well, do you need to examine the patient? And if they've got a bad head injury, let's say they came in with a Glasgow Coma scale of 6, I know what their CT looks like, they've got an ICP monitor, I don't need to necessarily examine them. I'd rather wait until their ICP is controlled. And one can look at, say, an ICP monitor or other monitoring tools as part of your clinical evaluation. You're not doing a neurologic evaluation, but you're measuring a parameter that then guides you. So again, you can titrate your therapy to that, just as you might titrate pressors to blood pressure. You can titrate your therapy appropriately. Years ago, I remember the nurses in our ICU used to take pride in when we made rounds in the morning that the sheets and the bed linen and that the patient was on was pristine without any creases, meaning that the patient hadn't moved during the night. And that was one of their ways of very simply showing that we've got them adequately sedated. We're doing what we can to best control their ICP.
Yeah, monitors don't have to be expensive. A sheet can do it for us.
Yeah, they seem to work pretty well.
Yeah. There's a very interesting question that we see here on therapeutic hypothermia. And I think indeed, this is one of the few therapies that has been researched a lot. And so we had the early Clifton trials, we had the the trials in the kids that were negative on therapeutic hypothermia. Then there's Eurotherm, which has examined therapeutic hypothermia as a second-tier therapy, which has demonstrated harm. And then the most recent Apollo trial has, for prophylactic hypothermia, has demonstrated no effect. And so the question is, what is therapeutic hypothermia, of course? Because to me, it's below 35 degrees. Anything above that can still be considered low normothermic. And as a consequence, at least in my hospital, we don't go below 35 for treatment of ICP. What has never been studied, and there's some discussion, I know David Mellon is very, it's a point he often makes in discussions. What has never been studied is therapeutic hypothermia in tier 3, like a decompressive craniectomy. So indeed, that is the only area of uncertainty that we still have with regards to therapeutic hypothermia below 35. And a trial would certainly be welcome there, but it's usually not necessary to go so deep. What we do, not applying therapeutic hypothermia does not mean that you can neglect temperature. And so we do keep every patient with an ICP problem in the 36, 37 degree range, as long as the problem is there. And in some patients, we go to 36 or 35 even to control ICP. Of course, mostly these patients also have an infectious problem at that moment, so it means you have to treat that. And it's still too early in that phase for them to develop paroxysmal sympathetic hyperactivity. So it's certainly not that. That's a problem that usually comes later, as soon as the ICP problem is there. But I don't know, Peter, what do you do? Do you still go for deeper hypothermia below 35?
I think, temperature control is important. So I prefer normothermia. I don't necessarily use hypothermia. It is rare that we use induced hypothermia as an ICP treatment in the third tier. There it tends to be decompressive craniectomy significantly more frequently, and then barbiturate-induced issues. The induced hypothermia can control ICP, so it works, but the trials really don't help as much because it's not being studied, as you say, in a tier 3 setting. Prophylactic hypothermia doesn't work or might adversely affect outcome. The one group of patients that I perhaps use it more frequently in is those with liver failure and hepatic encephalopathy. There, sometimes it works pretty well, and you can sometimes get the patient through to the point they get their liver transplant. So in that pathology, liver encephalopathy, there I think induced hypothermia is useful. That's perhaps the place I use it most frequently, and really don't use it that.
Do you put monitors in these patients as well, in the hepatic patients?
We have had. It's not that frequent. Obviously one has to be concerned about coagulation options, but as a resident, one of the first papers I wrote was actually the insertion of the old Charlottesville bolt into patients with hepatic encephalopathy, and that's a lot more of an invasive procedure than what we currently have. So it's feasible. Again, in these patients, you can tell by their clinical presentation, the CT, the EEG, and non-invasive monitoring that there's an issue. I think importantly with hypothermia, one has to be concerned about the negative effects, i.e. shivering. We've studied this in showing that patients who shivering have a significant reduction in brain oxygen because of how their VO2 max changes. So if you're going to use induced hypothermia, you have to make sure that you have a good shivering protocol in place.
Yeah, fully agree. I see we are at the end of the session. There's one more question I see about remifentanil. Do we use it? Yes, we do, for sedation and pain control indeed, and it's one of these easily reversible opioids, although in most of my patients I use fentanyl like Peter does, but if you prefer Remi, it's certainly perfect. I can't see any additional questions. Peter, do you feel ready for a wrap-up of the session?
Um, yeah, I think if there are no more questions, and obviously we've run out of time, they were very good questions, and I think very varied. So it's been helpful. I mean, I learned from questions as well, so I hope the audience has learned. I think the key thing that both Geert and I are trying to emphasize, and what's been emphasized more among the so-called experts in the field, if you read the CBIC consensus conference, is really to look at ICP as something that's treatable, but not just a single threshold parameter, but rather as a marker of something that's happening in the brain. So trying to understand the mechanism behind that is important. There are several therapies. We don't have good science for all of the therapies. I think the CBIC tiered approach is a very rational way to approach these patients. Ideally, if you're going to measure raised intracranial pressure, you should have an ICP monitor in place. You don't measure, you don't treat hypoxia or blood pressure without some form of monitor. So those, I think, are the key points. One always has to target an individualized care as well.
Yeah, yeah, I fully agree. I think the idea of the inter-tier square in the CBIC guidelines is probably the most important one, because that means look at your patient, look at the pathophysiology. So it's not just a number and then you throw at it what you think you have, but it's about why is this number elevated, and how can I help this patient? Is this a problem of activity? Is this a problem of perfusion? Is this a problem of edema? Should I drain? Should I? And so I think that's hugely important, to think pathophysiologically with the evidence we have, because on some of the interventions there's not a lot of evidence, but for instance on the temperature management we do have several good studies. I think we'd be happy. You probably can get our contact details as well. So if you have more questions or you feel that we haven't answered to what you would want, I'm sure you can mail Peter, and you can certainly mail me as well, and we will be most happy to answer. I think with that we can close the session. I'm not sure how it works, because we are the presenters, so I suppose we just have to leave. So thank you for logging in, and hope to see you next time live, hopefully in Brussels or somewhere else in a nice location. I was actually quite happy to be able to talk about something else than COVID for 30 minutes, because it's been the subject I'm always invited for now. Okay, thank you. Bye.
Thank you very much.